Hello, and thanks for joining us. I am Aaron Patzer, the founder and CEO of Vital Software. Vital makes AI powered patient experience software. Today, we are joined by Dr. Gus Garmel, who is a professor of emergency medicine at the Stanford University Medical School, a practicing ED doc, and so much more. I believe he writes for Stedman. So literally, when you look up dictionary definitions of things on medicine, some of it is his work. Thanks for joining us, Dr. Garmel.
Sure. Happy to be here, Aaron. Thank you for having me.
Absolutely. Before we begin, you're somewhat of an expert in what is now called patient experience. Maybe you could tell us from 30 plus years in the ED, emergency department, ER to the non hospital people in the world. What has changed in patient experience and what still needs to change?
The patient experience, which started as the patient satisfaction movement, is about 30 or so years in the making. And surprisingly, there was a tremendous amount of resistance from physicians to focus on the patient experience or patient satisfaction. There's always been sort of, I'm the physician and you're the patient, and it's my responsibility to do things that I need to do, and you are receiving or on the receiving end of my treatment and my care and my knowledge. And I think given that patients are the center of the healthcare treatment and the physicians are guiding or serving patients in terms of their healthcare journeys, the landscape has changed over the years to try to focus more on patient-centered care or the patient experience.
What are practical things that you would like to see instituted everywhere, and that perhaps you've already instituted in your own emergency department?
Sure. That's also another great question. And I think part of the plan of action for physicians is to really listen actively and give their full undivided attention to patients. I know everyone talks about the time or waiting time or time to see a physician. Those are metrics that are very important to a lot of people and a lot of organizations, institutions. Although I think sometimes patients just want their physician to be present. No matter how long it is, they want to be validated, they want to be heard, they want to understand what their physician is telling them and doing for them. And I think that the most important thing physicians can do is really drop into the experience that patients are having, to listen authentically and to communicate effectively. I think physicians owe it to each patient to really try their best to make sure that they don't feel rushed, that they behave in a way that's validating and sensitive and demonstrating empathy for the patient's concerns and issues and worries, and explain things in a language that can be understood. And I think that's one of the beauties of the Doctor-to-Patient Translator, that it helps patients understand physician shorthand, if you will, that they've placed in the medical record about the patient, that they can then reflect back on and understand or question if need be at some later time.
So you alluded to the Doctor-to-Patient Translator, which we developed. It's a large language model that takes doctor's notes that are full of what I, as a layman, consider to be medical jargon and a lot of obscure abbreviations. A normal person says heart attack. As a doctor, you say MI, short for myocardial infarction. Or one of my other favorites is NPO, which is nil per os, which is a Latin term of all things, which means don't put anything in your mouth, don't eat or drink. So literally like a foreign language to the rest of us, and translates it into something that patients can understand. This is brand new, using large language models, generative AI. There are no guidelines for this. And so safety and quality are always a concern for
Sure.
physicians who are looking to use this. Can you tell us, because you were involved a bit in the quality control, you used this before it went out to the general public last week. What was your experience with it like? How well did it work? Where did you say, wow, I can't believe it works this well? And where did you say, it's still got some work in these areas?
Sure. Well, it's a really important product, and I think it's wonderful that Vital is offering it, at least at this time, free of charge, which is a nice thing to be doing. It's, to backtrack for just a moment, I think physicians, not only because they're busy, but because of their training, they document in language that they are comfortable with. Because historically, physician notes were simply that, physician notes to document things for their own personal use or memory at a later time or for another physician. And with the Cures Act and open notes, now patients are expected to have access to their notes without delay. And that's a good thing. I think, again, physicians demonstrate a lot of reluctance to the open notes concept. And as you mentioned, there's a lot of medical jargon. You've mentioned some abbreviations. A lot of physicians use the abbreviation very frequently, SOB, for shortness of breath. But imagine if a patient's looking at that and wondering, does this physician really think that of me? So I think that similar to computer programming or computer coding, which is really for the programmer or the coder, it may not be understandable to a layperson. So there is a similarity to this. That being said, as a layperson, I don't need to see the computer code to understand what's working. And now the general public is able to have access to their medical records, which they should, their EPHI. They should, so they should be able to understand that. Whether it's up to the physician or not to write or document in language patients can understand, that's to be determined. But one of the things about Doctor-to-Patient Translator that is really elegant is that it takes, using HIPAA compliance and high trust and some other certifications, it takes that information from the physician's medical record that the physician documented and translate that into, very quickly, I might add, into information that patients can digest and use and understand. And I think that's a wonderful thing. I was very impressed. I did my own notes as well as some generated notes that I did, but I also used the example. I looked at the examples that were given. And I think did a wonderful job in terms of the translation, which I think is really great. It's mentioned that it's translated at the 5th grade level. I'm not sure whether that's an estimate or whether that's...
I tend to think that that's the instruction to the LLM. I honestly think it's a little closer to middle school or high school level language.
Yeah.
Is what actually...
Okay, I would agree. I would agree with that. But one of the things I really liked about it and very impressed is there's several things. One is the hover feature, where you can hover over a key term and it gives you a definition. Not only is that something that patients are familiar with, because we see that on websites and we see that in a lot of different electronic media, but that's something that's really a wonderful function, and I was very impressed with that. I also was very impressed with the 2 options for outline and detailed, where you can see a short version, a summary, if you will, or a detailed version, which is almost a line-by-line translation. And I think that that's really clever and really a smart feature of Doctor-to-Patient Translator.
We did a test with about 7 different physicians who graded a few hundred different imaging reports. And they deemed the translator to be 99.4% safe. So that outline that you were referring to, the details section, it didn't contain anything. It didn't miss anything that they thought the patient should be aware of. It didn't say you have cancer when you don't have cancer. It didn't mix
Right.
up the name of any medications ever. But everyone in healthcare is, worried about lawsuits and liability, and 99.4% is good, but it's not 100%. No AI will get to 100%.
Mhm.
What do you think a fair comparison is in terms of what accuracy would a physician have, looking at somebody's medical history during an emergency situation, before you went in to treat them?
In medicine or healthcare, our patients deserve our very best efforts, whether that's 90%, 95%, 99%. I think that 99.4% is remarkable, and I'd like to see that carried out to larger numbers of reviews. I do think that ongoing quality review or ongoing learning for the AI model is important, just like it is with humans. And I think that's one of the similarities, is that humans and AI will learn from mistakes. We just have to identify those mistakes or errors to then learn and improve. And that's part of the healthcare profession, certainly in emergency medicine, something called lifelong learning, quality review, quality assurance, quality control. I think you use that terminology. And I think that those are important parts of making the doctor-to-patient translator as important and successful as possible, is to be doing that ongoing quality review.
Another area that is ripe for translation into lay terms is the discharge summary.
Sure.
One of the things that I was wondering if you could give us some insight on is, why the heck do we give people 15 printed pages when they leave the emergency department instead of these are the 5 bulleted things that you need to do, in the next 24 hours after you get some sleep?
You're right. There's a lot of discharge paperwork that often gets left in the emergency department by the patient or their family. I think that the translator is important for the follow-up instructions. I like to think, and I teach, that the follow-up instructions or discharge instructions are the last chance for a physician to get it right. Sort of either service recovery or also the chance to reinforce what was done and what needs to be done. And one of the things that I would teach, and I've written about in discharge instructions, they're really, besides the patient name and the physician name, they're really 4 components that need to be done. And it can be done in a bulleted fashion, and that's the way I would do it. And I liken it to cooking in a recipe. If you're cooking and everything is written out as a paragraph, it's very easy to forget one of the key steps. It's much more easily remembered and followed if you have step number 1, step number 2, step number 3, step number 4 as a bulleted point. And in discharge instructions, it's really as simple, or should be as simple, as what to do, what not to do, when to follow up, and when and how to return to the emergency department. And if you use those 4 things, it really, for any condition and for any patient, it really explains well over 95% of what they need to do to follow, to be successful in terms of the follow-up information. So I did see that Doctor-to-Patient Translator uses the discharge instructions to translate that, which I think is great. But one thing to remember for physicians is that the patient instructions are given to patients and should be given to patients in language they should understand to begin with. And that's one of the challenges that I think is often overlooked, where physicians will use abbreviations in the discharge instructions that patients can't understand. And that would be something that in terms of teaching and supervising training that I do for medical students and residents, I would spend extra time reviewing the discharge instructions, because that is what goes directly to the patient. It needs to be very clear so they can follow the instructions.
Well, it should maybe be no surprise to all of us. I mean, you trained for a decade or more to be a doctor, and then you've accumulated decades of experience on top of that. That you would have your own unique language, and in some sense, I do think that it takes AI to turn that back into the language that people can understand. Really appreciated your perspective here. I'm really happy to have had you test the Doctor-to-Patient Translator before it went out in the wild.
Mm-hmm.
And I really appreciate your time today. Thanks for joining us, Dr. Garmel.
My pleasure, Aaron. Thank you.